Hello, welcome to the Johns Hopkins University Virtual GIS Week. You are currently in the session on GIS Lightning Talks. We're so glad you are here and excited for our panel of experts and their presentations this afternoon. My name is Brendan Fries, and I am a research analyst here at the Johns Hopkins School of Public Health Center for Spatial Science Center for Public Health. My co-moderator is Kara. If you'd like to introduce yourself briefly.
Hi, welcome everyone. My name is Kara Wigram.
I'd like to introduce our co-sponsors. GIS Week is sponsored by the Johns Hopkins Center for a Livable Future, an academic research center focused on the intersection of public health, the environment, and the food system, and the Johns Hopkins Spatial Science for Public Health Center, an academic research center focused on the development and application of spatial analytics, GIS, and spatial statistics for public health research. Before getting to the presentations, I'd like to go over a few housekeeping notes. We will be recording this webinar, and I will make it available after our sessions are complete. And please post questions for the speakers in the Q&A box. We'll have time for 1 or 2 questions for each speaker after their presentation. All right, let's get started. These are our lightning talks for today. We'll start with Jesse Berman. And once again, please post your questions as they come up, and we'll cover them right after each talk. Thank you.
Thank you very much, Brendan, for the introduction. Very much appreciated. And thank you for inviting me to come and present at the Hopkins GIS Day. So my name is Jesse Berman. I'm an assistant professor in the Division of Environmental Health Sciences at University of Minnesota School of Public Health. And I'm a previous alumni of Johns Hopkins Division of Environmental Health Sciences. And today I'm going to be speaking about chronic kidney disease in urban Minnesota and some work that we did looking at spatial patterns as well as environmental risk factors of it. So our project objectives were twofold. Number one, we wanted to investigate spatial patterns of chronic kidney disease in the Twin Cities area. And for those who aren't familiar with Minnesota, that's both Minneapolis as well as St. Paul and the surrounding counties. And we also wanted to evaluate the association between chronic kidney disease incidence and environmental conditions, including air pollution. For this study, we had partnered with the Fairview Health Services, which is a very large hospital system here in the Twin Cities. And for our study from the years 2012 to 2014, we were dealing with about 114,000 patients. For air pollution, we used the CMAQ downscaler PM 2.5 data, which is fine particulate matter, for daily estimates across that same time period. Next slide, please. So one of the issues when we're dealing with spatial data is, especially when we have 114,000 patients, is that this is a lot of points. And to put them all on a map simultaneously, it's very difficult to pick out spatial patterns. So instead, we use a tool called spatial intensity, which is understanding the intensity of points across a given area. And now all of a sudden, we can go from a mass of overlaying points to something which is more useful. So the map on the left is our intensity for cases, and the map in the middle is the intensity for controls. People should note that they look fairly similar to one another, which isn't surprising because this is where most of the population lies. But if we take the ratio of the two of them, we can start to see patterns that reveal areas where you do have a higher ratio of cases to controls. And that now shows different highlights of areas where you have clusters of disease. And I just want to point out to people is that the map on the far right looks very different from the other two. And several of these hotspot areas actually lie not only in city centers, but also near historical munitions factories and plants and other industrial areas. So this map really allows us to see spatial patterns that might be of further interest to examine. Next slide, please. One of the things that we looked at is, do we see evidence that you have chronic kidney disease clustering? So are cases more likely to be near other cases than controls. The figure on the left is something called a difference in K function plot. It's not important, or we don't have time to go over exactly now what it is, but it's important to notice that the black line is well above those two dotted blue lines, indicating that we actually have a clustering of chronic kidney disease cases over controls, and that this relationship is statistically significant up to, for this project, a distance of 10 kilometers. We then took this information and now brought a lot of it into a statistical model where we were looking at chronic kidney disease risk adjusted for individual factors as well as comorbidities, BMI, and neighborhood characteristics of SES education and long-term air pollution, which was our exposure of interest. And when we brought all of this information in, we found that there was no evidence of any residual spatial variation, implying that these factors of both community, air pollution, and individual measures accounted for those spatial differences that were observed previously. Next slide, please. So what were our conclusions to this? We found that in this Twin Cities metro region, the prevalence of chronic kidney disease showed both evidence of spatial clusters as well as neighborhood disparities. We found that higher levels of PM 2.5 was associated with increased kidney disease incidence, and this was particularly evident with severe CKD. I believe that further research, which is stuff that's still to be done, should focus on some of those CKD hotspots, which, as I mentioned before, visually matched with a lot of these major industrial facilities and former Army proving grounds. So with that, I would like to thank Dr. Lama Ghazi. This was really her work that she had done as part of her doctoral research, and Dr. Paul Draws from the University Minnesota School of Medicine. And these were the two people who led the bulk of the work. With that, thank you very much, and I'll be happy to answer any questions if we have any time.
Okay, so we have two questions. One from Frank, it looks like. Does higher air pollution match with those identified landmarks?
Overall, no. Those landmarks were not associated with clusters of higher air pollution levels. So we actually think that while we know that air pollution is associated with chronic kidney disease, there might be some other environmental exposure in those areas that could be driving those trends.
Okay, and we have another question. Did you assess the relative contribution of neighborhood versus individual predictors in the spatial distribution of CKD?
Yes, we did.
Great, thank you.
All right, well, thank you very much.
Hi everyone, Tom Crompton here. Brennan, I'm assuming I can go ahead. Yeah, I am the head of analytics at Right to Care in South Africa. Right to Care is a non-profit mainly focused on HIV and related illnesses in South Africa and sub-Saharan Africa. But we've done a lot of work in the COVID-19 response in South Africa. So today I just want to talk about the kind of fairly novel data source, especially in South Africa, where we use aggregated and anonymized smartphone mobility data and how that can be used in the COVID-19 response. So we've used it in three main areas, trying to predict where COVID-19 will go to and determine, once it's moved into an area, the localized potential transmission hotspots. And then also, once we find these localized hotspots, how we can send in teams to intervene at a really micro scale level. Can we move to the next slide, please? So starting on the left, just looking at how mobility patterns can be used to predict the spread of the virus. So what we have in South Africa is called districts, which is equivalent to states in the US. And basically the map is showing the active cases per 100,000. And all these lines show the level of mobility between the districts. And what we wanted to see is those two red districts in the bottom of your map, they were real hotspots in the country. And we wanted to see where the COVID-19 cases would go to next based on the current high or the current hotspots. And looking back in time and looking forward, we have seen quite a high correlation of COVID-19 cases moving in line with the mobility, as one would expect. But that gives us the kind of broad overall picture saying, okay, well, we're in state A or district A, where does it move to next in terms of district B? And once we've also done that, we can then look at, in a hotspot area, in a town or in a district, how do we zoom into that town and look for areas where COVID is potentially being transmitted. So what we did is created a 100 by 100 meter grid frame for the whole country. And we aggregate all the devices and points to this 100 by 100 meter grid frame and find areas with high dwell time and also a high number of devices and points within that 100 by 100 meter grid cell. And that gives us an idea from a whole district level or from the whole country, which areas we really need to focus on in terms of how we can send in a field team to go and intervene. So for example, in this town, we found that there was a cluster, that red circle in the second map, of high movement and high dwell time in this area. And when we zoomed in on that, it was around a post office. Now, a post office, once a month in South Africa, distributes a social grant. And lots of people, especially elderly people, congregated these areas to receive their social grant. And as we know, elderly people are very vulnerable for COVID-19. And the idea was to send a field team in to make people aware of health promotion, to ensure mask wearing and ensure social distancing. And I think you can see from the picture that there's very little masks and very little social distancing. And so our team went in there and it's been used quite effectively to slow the spread of COVID-19 in the country. Next slide, please. So just in summary, we saw a really strong link between the mobility between districts, but even right down to a small level, where cases might go to and where cases might come from. And this allows us to be one step ahead of the virus in terms of ensuring that all the necessary protocols are in place. And we've also seen that by using this aggregated and anonymized smartphone mobility data, we can find these transmission hotspots. And what was super interesting, because you have the smartphone data, you have the when. So we as GIS always know the where, but the when also gives us the time of day. So what we did is split that into work hours, weekends, and especially weekend evenings, where we were finding nightclubs and bars that were potential super spreader events, and allowed us to pick up these ones, especially in rural areas that we had never thought of before. And this allowed us to send teams in to ensure the social distancing, ensure the mask wearing, and potentially shut down some of the nightclubs because we have a curfew in South Africa that's preventing people from opening these. So I thought, we think it's a very encouraging data set for use in public health. And I think there's many more applications for it, but this is how we've used it for COVID-19. Thanks very much for your time, and I'm happy to answer any questions.
Thanks so much, Tom. We have a question from Tim. Can you describe how you obtained and manipulated the smartphone mobility data? And were there any privacy issues?
Good question. I should have addressed that because yeah, everyone asked it. So it comes from a third-party service provider, and that's all collected in an anonymized fashion per device. And before it comes to us, obviously we, in the public health sphere and very conscious of that, we get it aggregated. So the lowest resolution we'd use is that 100 by 100 meter grid cell, but usually even higher than that. So we don't know anything else other than the lowest point we'd get is 100 by 100 meter. And when people have an app, it's done through various different apps. They are consenting in those apps to collect that data. And yeah, to answer your question, we haven't had any privacy issues.
Okay, thank you so much. I think we'll go on to the next talk now from Victor. I think you're still muted, Victor.
Good day, everybody. I'd like to say thank you, everybody, for Brendan, for giving us this opportunity to present. My name is Victor Banga Mabo. I am from South Africa. I work as a GIS data officer at Right2K with Tom. What I would like to share with you is the ability and the application of GIS in strengthening local decision making in response to COVID. So the main of what I would like to present to you guys is basically how we use GIS to support daily response to COVID infections in Ihlanzeni district municipality in South Africa. So the main objective of this is basically what we do on a daily basis whenever we get the cases from the Department of Health is to map the actual location of positive cases as well as their contacts. And then from this, the next step we do is to derive the spatial clusters of the above positive cases as well as their clusters and monitor their spatial temporal changes at a settlement scale. The next thing basically we do is to focus on individual clusters that we've identified, and we try to zoom into things like the patients, the age of the patients, because we know age has increases the risk of the person, being affected by COVID. We look at their comorbidities, and then we also zoom into the occupation as well as the different business sectors that they might be coming from. Then from this, the next thing we do is to basically, we use this information to inform the response team so that they can be able to prioritize the screening, testing, and to also closely monitor the areas or the businesses that are affected the most. So that I think one of the reasons why we do that, we inform the government is so that they're able to target their interventions where they are needed. Next slide, please. Okay, so what I have here in front of you is basically the dashboard that we produce every day. And the dashboard basically shows on the left of the dashboard, it shows the different clusters that we would have identified within the district itself. And within that dashboard, the data of the patients would have collected, would have things like where their patients work, whether it's a learner, so which schools they're going to. And this allows us to periodically monitor which sort of industries or organizations are sort of sometimes not really complying with the regulations that the government has put in place to fight COVID. But looking closely at what we're seeing here, we're seeing the different clusters. The light blue colors, those are the clusters of the actual active cases. And the circles in black, those are the clusters for the previous week. And basically what this information allows us to do is to be able to monitor where the clusters of these infections moving in relation to the clusters and the locations of the contacts that these patients have been in contact with. So we send out with this sort of information, the Department of Health is able to basically go on the ground and focus their efforts in areas that we have already identified to be problematic. Next slide, please. So in conclusion, we've noticed that understanding the changes of the patterns of the positive cases, as well as the spatial patterns of the contacts of these positive cases, and where these cases work or where they go to school or so forth, is usually the first frontline strategy that the district uses to devise strategies to respond to COVID, whether they decide where are we going to send screening so that we can be able to understand what's going on with the infections we're seeing in an area, and then also be able to advise whether they need to start doing testing or do they need to send in their teams to do awareness, and then also to be able to understand where the high risk patients are. So in other words, the people who have comorbidities and are above a certain age. And then this also allows the municipality to be able to implement preventive and restrictive measures. So in other ways to do whether they do compliance monitoring of businesses and premises to see, or schools, to see why the cases keep increasing or, they are stagnant. Yeah, that's all I wanted to share with you guys. Thank you very much. I will be happy to answer any questions if there's any questions.
Great. Thanks so much, Victor. Yes, we have a question. It says, it seems that you're using SAT-SCAN for the cluster detection. Are you using a retrospective or a prospective scan statistic?
We are just using a basic for the clustering, how we identify the cluster. We're just using a distance-based clusters, a spatial analysis from spatial statistics. So so basically what we do, depending on the type of infections we're getting at a given time and the different phases of the pandemic we're in, we will define how big the cluster needs to be, and then also how many cases, minimum number of cases within a cluster for an area to be identified or to qualify as a cluster.
All right. Thanks so much, Victor.
Thank you.
Next up is Madeline Brooks.
Hi, my name is Madeline Brooks, and I'm a research associate at Christiana Care Health System in Northern Delaware. I'll be speaking about how we use GIS and spatial statistics to examine the spatial associations between tobacco retailers and our hospital-based population of current and former smokers. In this context, we compare current smokers to former smokers because we're really interested in environmental differences and cessation among anyone with a history of smoking. So I'll describe how we map the distributions of each retailer type and each type of smoker, how we describe differences in clustering between current and former smokers, and also how we examine spatial interactions between each smoker type and tobacco retailers. Next slide. Starting on the left, we map the spatial intensity or the spatial concentrations of current and former smokers, and then we mapped the ratio of those intensities, which provides a visual estimation of where the risk of being a current smoker is greater. And we can see that that risk of current smoking status is really elevated in northeastern Newcastle County, particularly in and around the city of Wilmington. We also wanted to examine small-scale variation or differences in clustering between current and former smokers. We calculated the K functions for each smoker point pattern and looked at their difference. And that difference is greater than 0 and greater than our confidence intervals, which tells us that current smokers are significantly more clustered or spatially compact relative to former smokers. Next slide. We also map the spatial intensity of tobacco retailers, as you can see in the map on the left. And similar to the previous map, the spatial intensity of tobacco retailers is very concentrated in and around the city of Wilmington, where we saw that the risk of being a current smoker was also elevated. So there's some clear spatial overlap there. We also wanted to look at the extent to which current and former smokers cluster around tobacco retailers. And we use the cross-K function for this, which tells us the extent to which each smoker type clusters around those retailers. And we took their difference again. And we see here that this difference is very high, and it tells us that current smokers compared to former smokers are significantly more clustered around tobacco retailers within up to 8 miles of any retailer. So these are reflecting major differences in individual level tobacco retail exposure. Next slide. Next slide, please. Thanks. In summary, we see that there is a lot of spatial overlap between current smokers and tobacco retailers, and these trends are particularly evident in the city of Wilmington. Now, Wilmington, compared to the rest of Newcastle County, Delaware, has a greater population of low-income residents of color. And like national trends, this suggests serious disparities in tobacco retail exposure and associated smoking status. Looking at the smaller scale levels of clustering, we also saw that current smokers relative to former smokers are not only more clustered, but they exhibit significantly greater clustering around tobacco retailers. Some of the advantages of using available point level data here, as we did for tobacco retailers and smokers, is that we can measure that small scale spatial variation as we did with the K-function analyses. We can identify disparate distributions of exposures and populations regardless of administrative boundaries used for aggregation, such as census tracts or zip codes. Finally, by linking built environment characteristics like tobacco retail exposure to electronic health record data for individuals, we can inform individual level treatment, such as smoking cessation care that accounts for a person's neighborhood context. We can also inform the development of community level interventions and policy change, such as restrictions on the number and density of tobacco retailers in neighborhoods with greater concentrations of smokers. I'd like to thank Scott Siegel and Frank Carriero for this support with the project. Thank you, and I'm happy to take any questions.
Have you thought about doing any like regression modeling with your data?
That's our next step. We're working toward a multi-level modeling approach where we'll account for individual level and neighborhood level variables that are associated with smoking status.
All right. Thanks so much.
Thank you.
And our next panelist, whenever you're ready.
Can you hear me okay?
Yes, great.
Hello, everyone. This is this is Sri Banerjee, and I thank you for inviting me to this talk, the Hopkins GIS Day. It's always great to come in and talk at your alma mater. I graduated from the MAS program with geospatial and public health a couple of years ago, and overall, I have about 20 years of experience in public health, trained physician. So this talk is about a certain type of regression analysis. Keep using geospatial considerations in mind. So in this talk, what I will be doing is going over some comparisons between a traditional ordinary least squares regression, linear regression versus spatial models. And then also demonstrate some of the impact that geography has on lung cancer mortality rates. So the main dependent variable that is being focused on in this portion is talking about lung cancer, aggregate lung cancer mortality rates at the county level through FIPS codes, things like that. So I'll show how the comparison was kind of made, and also describe, finally, I'll end with describing how the model choice can have an impact in how policy is created. Next slide, please. Okay, so this is kind of a busy slide, a lot going on, so I apologize for that in advance, but on the left, you can see these are the lung cancer mortality rates, deaths per 100,000, so population is already taken into consideration. And as you can see, kind of in the center of the country, over in the Midwest and or so, there's a lot higher death rates than say in California or the Western region. So there's definitely something going on here. So more formally, let me also explain what was going in the model so that you know what variables were placed in there and what these numbers mean on the right. So models 2 and models 3, that's what I'll be explaining. So the main focus was to try to determine what environmental factors are associated more so with lung cancer mortality. Specifically, what environmental factors did I look at? Well, one of them was fine particulate matter. These are inhalable particles, and they have been linked to quite a few diseases out there. So that's why lung cancer would be a logical end result because of this. So a lot of these particles, they're in the atmosphere, chemicals such as sulfur dioxide, nitrogen oxide, these are pollutants that are emitted from power plants, things like that, which is why that was a logical variable to incorporate. The other variable that I wanted to take a look at is the number of days that the county has experienced or the zip code has experienced a heat wave. And so the number of days related to that, so that is more looking at global warming types of variables. So these are the two main variables. And a third socio-demographic factor was incorporated in terms of percentage poverty rate. So these were the three main variables. First thing that was run is a global model, the ordinary least squares regression, the results of which I did not have space to fit on here, but indicated that there was a significant relationship. However, when through Monte Carlo methods, there was a spatial variability test that was conducted as well. From this Monte Carlo, which by the way was a very computationally expensive sort of test to run. But after this was run, I was able to tell that there was in fact spatial variability going on. So the next step would have been, of course, to run a geographically weighted regression model. These are the results. The first column is actually mean, not standardized beta. Then the standard deviation, minimum, median, maximum. And this was a Python callable program that was used in order to run this. The third one, model 3, is actually a multi-scale GWR test. So this is a regression analysis which goes a little bit beyond the GWR because it captures under the assumption, GWR has the assumption that all relationships vary at the same spatial scale across all covariates. But MGWR, why it is significant is that it's an improvement because it relaxes that same spatial scale assumption and allows covariate specific bandwidths to be optimized. So MGWR is calibrated with a backfitting algorithm, which was introduced by Frothingham. Next slide, please. So here's where the comparison really takes place. The Akaike information criterion is a wonderful tool to be comparing models. So the global scale at the bottom, and I'm referring to the bottom of the slide. So the global scale has a pretty high AIC number, 6871. As model 2 performs better than model 1, and of course adjusted R squareds were compared as well, and we saw the same thing. I saw the same thing, and then model 3, the multi-scale GWR model, is even better. So the main theme that is coming out of this talk, this part of the talk, is the fact that model 3 performed the best, and so the fine particulate matter, the more fine particulate matter, the higher rates of lung cancer deaths, and then number of days in heat wave, higher lung cancer mortality. So that concludes my talk. Thank you for listening.
Great, thanks so much. I have a question. Did you use Markov chain for that Monte Carlo?
Yeah, right. So it was an iterative process, and I took 1,000 repetitions, so it took about 2 hours to run. So yeah.
And I guess I have another, oh, we have another one here. Were models evaluated based on prediction, or would that be something to also consider?
Yeah, right, Frank, that was a really good question, and it's always good to see you on these talks. So yeah, definitely that the prediction, the predictability is something else. AIC is a pretty robust way to compare, but that would be something else to keep in mind. Thanks.
All right, thank you.
And smoking prevalence is something else that probably should be considered as well. Thanks for that suggestion, Madeline.
All right, our next panelist is Catherine.
Okay. Hi, everyone. I'm having trouble seeing the slides on my end, so I'll just assume that they're all good to go. So my name is Catherine Carpenter, and I'm a 2019 alum from the Opal Spatial program, and I currently work as a data analyst in environmental health research with Tracking California. And today I'll briefly talk a little bit about the spatial analysis I've been working on surrounding benzene detections that were found after the 2018 Camp Fire in Paradise, California. And just to give some background, one of the main concerns after this wildfire was that the town's water system was contaminated due to fire damage to the pipes. So there was a lot of testing that was conducted, and benzene was one of the main VOCs found in the water samples. And so besides the actual contamination levels, our team wanted to look at the sampling results from a spatial perspective to see where the contamination occurred. And the three main objectives that we looked at were to explore the temporal and spatial trends in benzene detections in Paradise Irrigation District's service lines that could kind of further explain possible contamination sources. And then next was to examine the spatial distribution of benzene contamination in standing structures versus destroyed structures. And lastly, we also wanted to determine differences in spatial intensity and spatial clustering between locations with the benzene detections versus non-detections. Next slide, please. And so one of the first steps was to map all the sampled locations. So this map on the left shows the maximum benzene detections at each service line for the entire sampling period. And as you can see, the majority of the samples, which are pictured here in the small gold dots, did not have benzene detections, but the samples that did have benzene appeared to be concentrated in certain areas of the system. And so with that in mind, we wanted to explore gas stations as a possible point source of contamination. So when we actually overlaid the gas station locations, there wasn't actually a clear spatial association. So another thing we wanted to look at were the differences in benzene detection locations based on structure status, which is shown here on the map in the right. And overall, there were more benzene detections from destroyed structures, but there didn't really appear to be a spatial pattern in destroyed versus the standing structures. Next slide, please. So I was also curious to do a more in-depth analysis to examine the apparent clustering of the benzene detection locations. And so I used a kernel-based estimator approach to explore the spatial intensity, which is shown on the map on the left. And then I used the K function to explore differences in clustering, which is shown in this chart on the right. And the two main observations were that one, there were areas in the system that had a higher risk for benzene detections. And then two, these locations with benzene detections were significantly closer together than expected compared to the non. And so the main conclusions from this research were that the both concentration and detection frequency of benzene actually declined over the months following the fire. And during that time, the water system was being flushed, and the highly contaminated sections of the pipe were replaced. And so the main theory is that the benzene contamination was most likely due to combustion byproducts pulled into the service lines due to a loss of system pressure. And the spatial analysis that we ran ruled out that benzene contamination was from these a potential source, which was the gas stations. And then the fact that the benzene concentrations were highest in service lines to burned home is kind of highly consistent with the negative pressure hypothesis. And also benzene contamination in the service lines appeared more concentrated in certain areas of Paradise Irrigation District's distribution system. And this was shown in the previous two slides by the estimated odds ratio and also the cluster analysis, which overall showed that there was an observed spatial variation in the risk of benzene contamination in these service laterals based on the system, the service connection system, which had approximately 9,800 service lines that were actually destroyed during the fire. And with that, I just want to thank my PI, Dr. Gina Sullivan, and also the National Institute of Environmental Health Science, who funded this study, and the Paradise Irrigation District and the California Water Boards, who helped gather the data for this. And there are multiple components of this research, and I mainly worked on the spatial analysis, which was very kind of exploratory. So I'm definitely open to comments and suggestions on kind of how to approach this type of data. Thank you.
Thanks so much, Catherine. We have a question from Frank. Were point sources other than gas stations considered?
We didn't really look into any other point sources. That was kind of one of the main hypotheses. The other was just that kind of the destruction of the service lines itself and the reverse pressurization in the system is kind of the main source of how benzene could leak into the system.
And we have another question from Jesse. Have you considered including locations of HAPs which you can stratify by historical benzene emissions?
We haven't looked into that at all, but that's actually a very, very good idea.
All right. Thanks so much, Catherine.
Thank you.
Next, we have Jonathan Gross.
Great, good afternoon. I'm Jonathan Gross. I'm an epidemiologist at the Baltimore City Health Department. I'm also a Hopkins alumni through the advanced academic program where I completed a GIS certificate in the graduate school. So since March, my main three objectives have been to identify space-time clusters of confirmed cases of COVID-19 to identify potential outbreaks. We also matched COVID-19 case data to facilities list to create reports and line list of cases by different facility types. Lastly, I created an internal COVID-19 dashboard using R-Shiny to help inform decision-making and also to help establish testing priorities. Next slide. So for performing space-time cluster surveillance of COVID-19 using SAT-SCAN, that was a big challenge because of how quickly we had to do it. But fortunately, we had received a grant a few years prior to look at non-fatal overdose clusters using SAT-SCAN. So we already had code. And this is a really important point for funding public health programs that often code used for one purpose can easily be repurposed to look at another disease or condition. And you can actually find the code available on GitHub along with other folks' code in different jurisdictions that are using SAT-SCAN for COVID-19. One of the challenges we had for matching list of COVID-19 cases to different types of facilities list was the lack of standardization across lists. So the solution for that was making address cleaning code that uses a lot of string functions and regular expressions to parse out and split out bad pieces of info in the address line, for example, things like apartment or suite numbers. And then we geocoded both the case and facilities list with the same locator. And then we used the match address field in ArcGIS to standardize addresses across list. We also look at high frequency locations and also match case addresses to what's called real property, or the state's real estate database. The last challenge was too many maps and too little time. My typical work is around violence prevention and overdose prevention in the city with heavy spatial components. And COVID-19 really pressed me and a lot of the other epidemiologists and data people to do as much work in as little time as possible. So I created an R Shiny app that taps into the different data sources. And this allows users to select different weeks or range of weeks to look at different maps for things like the rates of COVID-19 cases, the percent positive, the number of people tested, and the percent of population tested, and how that varies over time. There's also a correlation explorer, so people can look at, for example, what factors might be associated with higher rates or higher positivity or higher percent of population tested. Next slide. So in sum, these products are used daily by our contact tracing team and outbreak investigation teams, along with our senior leadership. When we're talking about COVID-19, and as you've seen in the other presenters' talks, there are many sources of location data for COVID-19, whether it's things like cell phones or someone's mailing address, their place of employment, what college or university or what grade school they go to. A lot of COVID-19's impact is within facilities. So places like nursing home, assisted living, senior housing, correctional facilities. There's also what we call sort of locations visited. In the contact tracing data, where have people reported that they've been recently and where they might have been exposed to COVID-19. And then there's also things like ordering provider or the testing facility. So GIS and statistical analysis has also been used for establishing testing priorities. A special thanks to Dr. Darcy Phelan Emmerich for feedback on this presentation, and Anton Kivett for development of the non-fatal overdose surveillance code, which we've repurposed for COVID-19.
Thanks, Jonathan. I have a question about the geocoding. So did you guys have to tweak the geocoding you used for non-fatal overdoses to get it to feed for, to turn it into usable addresses, or turn from addresses into usable data compared to what you had for non-fatal overdoses? Or is it still that mix of healthcare facilities and things like that? Because it strikes me there probably aren't a ton of non-fatal overdoses in, say, like assisted living homes and things like that.
Yeah, as compared to something like the lab file for COVID, which is really large. And so the address cleaning was a lot more substantial, particularly for the lab file for COVID, requiring a lot more complex things, but also just sort of keeping up day to day with common addresses, or high frequency addresses that might not be matched, and catching those and making sure that corrections are made sort of on the fly.
Was that did you just use a human to check the addresses that didn't match using the application you created?
Yeah, I mean, the first thing is to basically, one of the big things and sort of easiest stumbling block that a lot of folks come across with a big sort of ugly address list is getting rid of things like apartment, units, suite, and floor. And so once you sort of parse out that, and you can also use different string expressions as opposed to having to sort of list out, every address. You can actually create rules that catch a lot of things. But yeah, then also sort of looking at those unmatched addresses and then making corrections and maintaining that list as well.
All right. Thank you so much, Jonathan.
Thank you.
All right, our next presentation.
Okay, hi everyone. My name is Tingshen Chan, and the project I'm going to share is examining county-level mental health using Facebook COVID-19 symptom survey data. And this project is led by Dr. Elizabeth Stewart. And in this project, we're interested in the prevalence of depression and anxiety at the county level over time during the COVID-19 pandemic. And our main objective is to examine the relationship between the prevalence of depression and anxiety and county level factors. And these county level factors include several demographic and socioeconomic factors, as well as the number of new COVID-19 cases. Our mental health data are obtained from the Facebook COVID-19 symptom survey data, which include more than 13 million individual responses from April 6th to present across all US states. And respondents are asked about their mental health over the past 5 days in the survey. So we classify subjects as being depressed or anxious if they reported feeling depressed or anxious either most of the time or all of the time in the past 5 days. Because characteristics of neighboring counties are often correlated, this presentation will focus on how we evaluate spatial autocorrelation and the process of modeling mental health prevalence as a function of the county level factors. Next slide, please. So here the maps on the left show the prevalence of depression in most US counties from September 2nd to September 8th, and from more recent week, which is October 30th to November 5th. We calculated the prevalence as the weighted proportion of respondents classified as being depressed. So we can see from the maps that overall the prevalence of depression is below 0.25 in most counties. And visually, the rates do not change much over time. And the high prevalence of some darker areas on the map is actually due to small sample size, so these may not accurately reflect the true depression prevalence. So as a first step for detecting spatial autocorrelation, we fitted basic linear regression models with random intercepts for county on a subset of the data, and we evaluated the residuals. So here we show the spatial analysis results after fitting a random effects linear regression model on data in a week period from September 2nd to September 8th, with daily county level depression prevalence as the outcome. And our predictors included several county level demographic and socioeconomic factors, and also the number of new COVID-19 cases in that county in the past 7 days. We included random intercepts for county in order to account for the multi-level structure and also to help alleviate spatial autocorrelation. So the residuals were plotted on the map shown in the middle, and we can see that there's no obvious clustering of residuals. We also generated a semi-variogram shown on the right to assess whether counties closer together have smaller variance among the residuals. And we can see that the degree of dissimilarity doesn't increase much with distance between counties. Next slide, please. So based on the spatial analysis results, a random effects model with random intercepts for a county is sufficient for explaining away spatial autocorrelation. So we will proceed with building random effects models to predict county level mental health prevalence using data obtained from the Facebook COVID-19 symptom survey. And our preliminary results suggest that counties with higher mortality and higher unemployment rate, lower median household income, and more COVID-19 cases may be more vulnerable to mental distress during the pandemic. So the next steps for this project will be to include a time variable in the mental health prediction model in order to incorporate mental health trends over time. And also we want to increase model complexity by adding more county level factors. And finally, the project will formally examine how demographic, socioeconomic, and COVID-related factors associate with mental health at the county level. And our end goal is to hopefully provide insight into which counties are most vulnerable to mental health problems during the pandemic. So this is the end of my presentation, and thanks so much for listening. I'll be happy to answer any questions.
All right, we have a question from Annie. Did you think think about looking for spatial autocorrelation by region, given that the size of counties varies a lot between areas of the US, like in the New England versus the Southwest?
Oh, we haven't looked at spatial autocorrelation by region. We only look at the county level, but I think that's a very good suggestion, and we can look at that further.
And we have another question. Did you ask participants if they experienced depression or anxiety symptoms before the COVID-19 pandemic versus after?
So in the survey, the question is asking the respondents about their mental health in the past 5 days.
Annie was mentioning that yes, so for the regional analysis to look at it still at the county level, but subset when running the statistics to test for spatial dependence by region, I believe, or within region.
Okay.
All right.
Yeah. Thanks for
Thanks
the
so
comment.
much. All right, Paulina is our next presenter.
Hi, everyone. Can you hear me okay?
Yes.
Okay, great. Well, first, I just want to say thank you to everyone for the invitation. It's a true pleasure to be here with you today and to be among such a great panelist team. So thank you all so much. So my name is Paulina Sosa. I wear two different hats. So currently I am in the public health informatics doctoral program. I'm actually in my dissertation at the moment, which is exciting. And the other hat that I'm wearing today is as the chair of the Latinx COVID-19 task force. And so the objectives of today's presentation is essentially in the midst of the COVID-19 pandemic, we've known, and I'm sure many of you that are watching today have noticed just the slew of disparities and gaps that a number of different communities across the country are facing, including the Latinx community. And so in the Latinx COVID-19 task force, what we have been tasked with essentially is to identify what those gaps are, and more importantly, to identify key Latinx serving resources and organizations across the country, which is what today's map and dashboard will show you. And essentially the main objective of this dashboard is to provide an easy to navigate map for the Latinx COVID-19 task force, both internally, but also externally, to make sure that anyone in the general public, public health authorities, anyone that is being faced with decisions in the midst of this pandemic knows where they can go to get those resources, but also to ask key questions that address Latinx communities. And so this, of course, also promotes collaboration and connection via GIS mapping tools and other tools such as Tableau and R. So we can go to the next slide. Thanks. So these are just three particular maps that we have used based on the qualitative data that has been provided to us from our partners. So as you can see, these are pretty basic maps in comparison to some of the other analyses and distributions that we are currently developing in this dashboard. But why the simplicity of these maps I first want to talk about is, again, a lot of the people that we are working with are health authorities or just the general public or community health workers and promotores. And so we are trying to make this as easy to navigate as possible, right? And so what we see in this first map is the Latinx serving organizations that we have been getting onto this coalition. So many of you are, I'm sure, you know, in different parts of the country. And so as you can see, when we first started, there was a huge gap within the Midwest. And so I'm happy to say that within the last couple weeks, we have actually started to fill that gap. But those organizations are key organizations that are within the coalition of the task force. And again, when you basically hover over each pinpoint, you'll see the name of the organization, the location, the city. So it's a very user-friendly interface that we're trying to develop. The second map what we see there is a hotspot by state and status. So what you'll see, and it's a little difficult to see on this slide, but basically based on the state, you'll see that there's a number of different organizations and hence resources that are provided for Latinx communities, and it varies based on the state. And again, unfortunately, you can't completely see this here, but you'll see that in the dashboard, a lot of the resources and organizations we have are at the border, which means there is a higher density of a Latino population in these states. And so in many ways it makes sense. But when you break it down even further, when you're, let's say, in Texas, and you break it down to the border in the Rio Grande Valley or in San Antonio, you'll see the division of different organizations and different types of resources that are available for different communities in that city. So that's the great thing about the dashboard. You're seeing this national version, and then you kind of zone in to get the local and more specific data. And then the third map that I included in this slide is a hotspot by state and category. And so the categories that we have are ranging from organizations that address Latino communities around culture or around education or around health. And so what we had is, again, just a very diverse group of organizations that are part of this task force that address these different perspectives. And again, they all come together to really provide this holistic perspective on addressing and how to address appropriately the Latinx community. And so again, what you can kind of see here is that the number of our organizations and our resources are kind of along the border, but also we have quite a lot here in the DC area, as well as in New York and further north. So it's been really exciting kind of getting this together, and there's still a lot more to go. So we've been getting more and more data in, and we're going to start populating this with population data as well. So actually we can go to the next slide. So what we'll see is that, you know, I'll jump to the next steps. One of the things that we're doing right now is we're doing a qualitative and a quantitative data collection, both with our partner organizations. So we currently have over 100 partner organizations, and we're trying to get all this data. And what we're going to do is overlay that with the population census data that we have, but also with the COVID positive data that we have, right? So we're going to be bringing in different data sources, which is going to beg, of course, the question of making sure that the quality of the data stays high, but as well as is really representative of what we're trying to do in this dashboard. And just to go to some of the main results and conclusions that we've based so far from this dashboard is the ability to really show representation of Latinx serving organizations. We've been able to provide guidance on where there are gaps and what specific next steps we need to make sure that we're as representative as possible of the community. And then of course, just kind of geographically showcasing the organizations and the resources and where they're available. But this really does get at being able to provide community and decision makers with the reality of resources at the local level. So with that said, I want to just say a thank you to the Latinx COVID-19 Task Force and the data committee within the task force. This is definitely just the start of this dashboard, and there's much more to come. So thank you all so much for taking the time to listen.
All right, thank you so much, Polina. Do we have any questions? Tim asks if you could describe the dashboard architecture.
Sure. So I'll try not to get too into the weeds with it, but essentially the architecture of it, kind of like I mentioned previously, it starts out with this very general overview. So there's the national level, and then it drills down to the state and city level. And so when you drill down, what you're going to have is the ability to aggregate by category or by type of organization. But one of the other things that we're hoping that this is going to be useful for local health authorities, is the ability to show, based on hotspots of COVID, of COVID cases and positivity, is, the ability to show the different resources in that area. So that's kind of the general description of the architecture, but there's of course a lot more in the background, how we're connecting to our data sources and how we're representing the data that we are connected to. So I'm not sure if that gets at the specific question, but I hope that provides a little bit of insight into how we're building it out.
Great. Thanks so much, Polina.
Thanks, Brendan.
And so on to our last presentation.
Can you hear me?
Yes, we can hear you, Renee.
Okay. Well, hi and good afternoon to everyone. My name is Renee Ori. I have a master's in spatial data analysis for public health issues. And in 2018, and from since then, I branched into entrepreneurship as well as GIS and analytics in business. And as such, I own 2 companies, well, 3 this week. Volta Research and Business Analytics, the Ori Maharaj Family Foundation, which is a nonprofit organization, as well as of this week, a Montessori school. So, next slide. So what at least these 2 businesses that I own address is utilizing GIS and ArcGIS, particularly in business and in the public health sector. And so this is where GIS really shines. So right now, the picture in the backdrop is actually from the Rohingya refugee camp in Kutupalong. It's actually taken by a photographer in the Kutupalong camp who is a refugee. And so the GIS helps with analyzing the camp, looking at all these different factors that you're seeing here. The supply chain management, the explaining relationships, the public health data, defining possibilities, location analytics. All of these are needed to reform the camp because currently there are over 2 million people in a camp in Cox's Bazar in Bangladesh. And they are not in permanent structures. They're actually in temporary structures, makeshift structures with blue tarps covering the top. And you could check a satellite image. Actually, the first image, could you flip back to the first image, please? If you look on the slide, you're seeing these makeshift structures, and they're either some sort of palm or mostly the majority from a satellite image, you would see that blue tarp? That's what you see. Okay, go back. Next slide. Okay, next slide. So this is what we do. We actually utilize both. So from the previous presenters, you guys have learned how to use GIS with research and data collection in the public health arena. So this is where instead of just analyzing public health data, we look at external factors. Well, not external directly. They are basically on a tiered level. So everyone thinks that public health is just concerned with just doctors and researchers. No, it's actually concerned with community health workers. It consists of firemen, policemen, everyone in the community. And so this is where we utilize GIS to determine where to put a clinic, where are workshops, where are the schools. This is how we track as well movement of people. So if we see for cholera data specifically, that there's clusters in specific areas, we don't only look at, okay, the cluster data. We look at to say, okay, what is there? Are there schools there? Are there, what roads are there? What clinics are there? What is the foot traffic? So that we can determine more better what is the cause or what is causing the rate at which the cholera would be spreading. What is causing the rate at which the COVID-19 is spreading. Next slide. So this is just, so in business and not so much outside of it, there are business decks developed. So each one of my businesses has a business deck. And this is one for the nonprofit organization for developing a community health worker program in Kutupalong camp. And as you can see, so OMFF is our organization, the Ori March Family Foundation, and we deal with the analytics, the spatial data analytics, which we work with the refugees in the camp so that they can develop businesses, have better health clinics in more strategic locations. So you can't just go and put a clinic where you feel to put it, which is what has been done in the past. And so, thanks, Brandon. So that's what mainly we've been doing with the GIS node. Go to the next slide. Okay, so this is more in detail of what we utilize and how we utilize it. So there's a digital supply network initiative, the marketing development, the corporate security, and we utilize issue business analytics and issue web apps. Next. All right, and that's about it. So if you would like to know more information or more in depth of what we would like, what we do and how we do it, or you want to get involved, please feel free to contact me via email or just send me a text. We have a book that is coming out from our camp this Christmas to aid with the Rohingya refugees COVID crisis. So thank you for your time, and thank you everybody for having me here and to being part of your team. And yep. All right, and there's a question. Oh, there's no question. Okay.
Thanks so much, Renee. Yeah, we'll open up to questions now if anyone has any.
Well, if anyone has any questions, just send me an email or a text, or look me up on Google and use one of those communications to contact me.
All right. Thank you so much, Renee. All right. Thank you again for all our presenters. Those were all fantastic presentations on a diverse variety of GIS subjects. Again, this recording will be available after all of the sessions are complete on our event landing page. We have 2 more sessions left in GIS week, and those are both tomorrow. So if you're interested, feel free to check them out. We'll put the registration links to the sponsored webpage in the chat box in a moment. And thanks again to our co-sponsors, the Center for a Livable Future and the Spatial Science for Public Health Center. If you're interested in learning more about either center, we'll also drop their links in the chat box as well. Thank you, and enjoy the rest of your day.
Thank you, Brandon.
Thank you.